All right. Good evening, everyone. We have a great audience here tonight. My name is Rhiannon Adams. My pronouns are she, her, and I'm a proud supporter of the Louisville Hospital Women's Society. I'm also the chair of the Supporter Experience Committee. For those of you who do not know, the Louisville Hospital Women's Society is an organization of people in all ages and stages of life, passionate about and committed to raising excellence in women's healthcare and treatment. The Society raises awareness and important funds for a variety of initiatives at the Louisville Hospital for Women. While this lecture is predominantly virtual, completely virtual, I wanted to emphasize that our passion doesn't rest with events online. This past year, with the opportunity to return to in-person events, we've been able to celebrate our 5-year anniversary with SYC Brewing, and more recently host a shopping event with Simon's Fashioning the Future, and raising $25,000 for the Indigenous Culture Partnership at the Louisville Hospital for Women. Since its inception, the Women's Society has been able to raise $850,000 in support of the hospital, supporting equipment such as the Firefly, which is an upgrade to the Da Vinci surgical robot, and the OBIX perinatal interface system. So thank you so much for supporting the Women's Society and our mission. We host our Mind and Body Talks as an inclusive speaking series to engage and stay connected with our community. A big thank you, as always, to Alberta Blue Cross for the continuous support that allows us to run this informative series. So please welcome Trish from Alberta Blue Cross.
Hi, Rhiannon. Thank you so much. So my name is Trish, and I'm with the Community Impact Team at Alberta Blue Cross, and we are very happy to be able to support such a meaningful program. I'm honored to be here tonight to respectfully acknowledge that we are on the traditional lands referred to as Treaty 6 territory. We recognize that the City of Edmonton and us, the people here, are beneficiaries of this peace and friendship treaty. Treaty 6 encompasses the traditional territories of numerous Western Canada First Nations such as the Cree, Saulteaux, Blackfoot, Métis, Dene, and the Nakota Sioux. We are taking this important moment here today to acknowledge all the many First Nations, Métis, and Inuit people whose footsteps have marked these lands for centuries.
Thank you, Trish. Now, before we dive into tonight's session, I'm going to provide a quick overview of the evening and a couple of housekeeping notes. So tonight, we're honored to have our guest speaker, Dr. Spencer Proctor. We are hoping that you will come away from this presentation feeling educated about all the ways women's health continues to make strides through focused research and the future of women's health in Canada. So this is a safe space for all to come and have their questions answered. If you have a question for our speaker, please type it into the chat box and we'll read it during the Q&A session following the presentation. My colleague, Brianne, who is a member of the Supporter Experience Committee with me, is going to be the one who's going to be moderating that section, so you'll see her in a little bit. This lecture is being recorded and will be posted on the Women's Society YouTube channel tomorrow. Tonight, we are using Zoom webinar. So each of the panelists, me right now, will appear as they speak, and you don't need to worry about your own video being displayed. So we hope that you enjoy this viewing experience. We are also using a live transcript function. So if you want to see the available transcript, please enable this on your personal computer. And there will also be an email survey emailed to you. You'll get an email with a survey following the lecture, as we always love to hear your feedback. So everyone who fills out a survey will be entered into a draw to win a $25 gift card courtesy of Alberta Blue Cross. So Dr. Spencer is a full professor at the University of Alberta, and the director of the Division of Human Nutrition. Dr. Proctor is a primary affiliate with WICRI, so the Women's Children's Health Research Institute, the Alberta Diabetes Institute, and a group of excellence in lipid metabolism on campus. He has a long-standing history of teaching in nutrition and dietetic I'm going to say it wrong. I'm sorry. Dietetics. Correct me when you get here, at the U of A. Dr. Proctor trained as a cardiovascular scientist, and his research program has spanned many aspects of how nutrition impacts the risk of heart disease, especially during chronic disease like obesity and diabetes. Dr. Proctor has over 120 peer-reviewed publications, which is amazing, congratulations, and has received numerous awards for his international contributions. And his research has been supported by CIHR, the Heart and Stroke Foundation, and CIRC, as well as Wickery. Most recently, Dr. Proctor has been a leader in understanding metabolism of fats in younger populations, obese and overweight youth, as well as discovering the relationship of fat intolerance and high remnant cholesterol in female cohorts, the latter of which is the focus of today's seminar. The differences in cardiovascular treatment and outcomes and women's heart health. Will everyone please welcome Dr. Proctor.
Thank you very much for the introduction, and it's a real delight to be here this evening with such a fantastic audience. And I must say, not only thank you for the opportunity, but congratulations to the Mind and Body Initiative and its ongoing success. I'm going to just share my screen, and I'll just use a laser pointer this evening, nice red one. So without further ado, what I'd like to start with is just to give you an idea of some of the topics that I would like to raise and discuss this evening. Hopefully you got one other television or eye on the hockey game at the moment, so I forgive you if you're a little bit distracted. What we'll try and talk about is a little bit more in-depth understanding about heart disease, and maybe emphasize some of the pieces that we don't know. I have a couple of comments regarding how heart health is different in women versus men. And I'd like to try and present to you some new research about poor fat metabolism and how this poor fat metabolism or fat intolerance can contribute to heart disease. There's a couple of different ways of measuring this poor fat metabolism. And as was introduced, I'm going to talk a little bit about this remnant cholesterol, this form of remnant cholesterol, which hasn't been talked a lot about, but I'd like to raise this for your interest this evening. And then just towards the end of my talk, I'd like to share with you some new research, which is primarily Alberta-based, and it's primarily a cohort of women. And we've been measuring remnant cholesterol in this particular cohort, and I'd like to share with you some of the significance of that work. So when we talk about heart disease, I thought I'd start fairly simply. We often think of heart disease as a bit of a plumbing problem. We have a number of diagrams here of a healthy artery where the blood circulates rapidly and under pressure. And what happens during heart disease is that these arteries slowly are blocked and accumulate different types of lipids. And so you'll hear different forms of terminology of lipids, and I'll try and explain that as we go through. But just to start with the notion that this vascular disease can happen in various places throughout the body. It can happen in the brain, it can happen in the lungs, and of course, we hear a lot about heart disease, which is vascular disease within heart vessels. Some of the other terminology that you often hear is vascular disease, which is what you see represented here. And there's a fancy term called atherosclerosis, which is really just the blockage of particular arteries. And this is a process that can happen in various places around the body. To understand how this vascular disease begins and ultimately causes some complicated issues. And of course, a heart attack or a stroke are some of the things that we're familiar with, and we want to try and understand and avoid those situations. Represented here is a healthy artery, and you might be surprised to know that much of this vascular disease does start very early on. And in younger adults, the process can begin quite silently when you have just a small buildup of this lipid within the arterial wall in a blood vessel. And over time, the accumulation of these lipids becomes a lot more complicated, and there are cells and different types of lipids that form. And there's also a fibrous plaque or a fibrous cap that occurs over this lipid accumulation. And I'll talk a little bit about this fibrous cap a little bit more, because it is related to how we see differences between men and women. And some of those differences can be seen with the development of this fibrous plaque. Throughout life, and as we get a little bit older, or as this disease progresses, we see the continued accumulation, and it's this accumulation and blockage within the arterial wall that actually causes the damage. It can increase blood pressure, and it also, in small vessels, it can completely occlude those blood vessels, limiting the blood supply and limiting the oxygen supply. And this is what we see sometimes during a heart attack, often called a myocardial infarction, where spontaneously these blood vessels will block and not allow certain areas of the brain or the heart to receive ongoing oxygen. And in my analogy here, sometimes I like to remember that this development over periods of time is very much like filling a pressure cooker. And so at the very early stages, we see the pot is slowly filling. In the intermediate phase, you see this increased pressure in a cooker. And the fibrous plaque that I mentioned really is a way of the body and the blood vessels trying to contain all this lipid within the vessel and not to cause any more damage. So if you can think of this containment as a good, healthy response to the accumulation. And it's the next third stage that we really get worried about, which is when the pressure cooker is overflowing and it actually ruptures. And we use the plaque rupture terminology as a way of describing how the contents of these atherosclerotic plaques can be released. And that's when you have a very dangerous situation that can cause a number of the symptoms that we've been talking about. So now that you know a little bit more about the accumulation of lipids, this is what it looks like inside the vessel wall. So it's a lot more complicated, of course, at the cellular and molecular level. But here I just want to highlight again that amongst all those complicated processes, we have the early stages, we have the mid stages, and we have the later complicated stages. And it's these second and third stages that I'll refer to a little bit later on when we talk about some differences between men and women. So now that you know a little bit more about the essence and the fundamentals of vascular disease, a few extra comments just to give you some overview of vascular disease as a whole. We know that it begins in childhood, and the severity and rate of that particular development depends on a number of different things. And you've heard risk factors like genetics, lifestyle, dietary habits, and smoking. These are all different and individual things that can impact the rate of vascular disease and ultimately how quickly you might proceed to having a heart attack during your lifespan. We also know that there's important time points around 14 to 16 years of age when men and women start to have differences in their vascular disease risk factors. And this is primarily due to the increase in estrogen and testosterone androgen levels. We also know that women between the ages of approximately 16 and 60 years of age can be somewhat protected from some of these clinical events of cardiovascular disease. And it appears on average that men are a little bit more susceptible to heart disease risk earlier on in life. And I'll talk a little bit more about that. However, the reverse is also true, that post-menopause, women begin to lose this particular benefit of estrogen and can rapidly increase their risk of cardiovascular disease, which is of great interest because it really needs to be better understood for those particular individuals. Let me just give you two quick examples of how testosterone and estrogen implicate themselves in cardiovascular risk. You can see here females on average to the left have approximately about 30 nanograms per deciliter of circulating testosterone, which is much lower than the average male circulating concentrations, which are about 500 nanograms per deciliter. Men on average have a lifetime CVD risk, and they tend to have a higher risk than women. Women are considered to have an overall average reduced lifetime risk, primarily because of reduced testosterone over the lifespan. It is also true that during situations of higher circulating concentrations of testosterone in females, and there are a number of different clinical situations where that occurs, it then does increase the risk of those individuals who have higher circulation concentrations of testosterone. The reverse is also true for estrogen and estradiol levels in women. This is just a schematic of different examples of how estradiol can be reduced during the number of years around the final menstrual period. So the first thing you notice is that this can happen over quite a number of years. And you can see here some numbers between 8 years preceding that final menstrual period and up to 8 years post the final menstrual period. And you can see here different patterns of how women may gradually lose those concentrations of estradiol. There are women who have high peaks that then quickly and rapidly fade. You also have examples where women can gradually and more linearly lose their estradiol circulating concentrations. And this helps to explain why every individual in this situation can be slightly different. It depends on a particular age range, and it also depends on how the body is responding to that loss of estrogen. So how does that look with respect to the blood vessel? So we know that high circulating concentrations of estrogen in women are in approximately 16 to 60 years of age is somewhat protected. What does that mean? Well, from a mechanistic point of view, we know that estrogen has certain effects on inflammation and certain processes within the vessel wall as the atherosclerosis and heart disease progresses. And we call this more related to the second phase of heart disease development. Some of the descriptors here, like having a small plaque or a thick fibrous cap, creates more of a plaque erosion phenomenon. And this is going to be very different compared to what males experience. On the other hand, or in comparison, males between 16 and 60 years of age have high levels of testosterone. And this does quite the opposite when we think about certain cell types and certain inflammatory processes. It can promote certain cell types and it can increase certain inflammatory types. The descriptors for the male development of heart disease and vascular disease are larger plaques, thinner fibrous caps, and we use words like plaque rupture, which is related to this final third stage of dangerous development, where if we have plaque rupture, it creates that dangerous situation that potentially can cause a heart attack or a stroke. Within the arterial wall, estrogen is known to influence some of these processes from a cellular and molecular level. In contrast, we see this third phase, which is caused by higher circulating testosterone, which creates greater instability of the vascular disease that we see in men. And this helps to explain why women might appear somewhat protected during these early years and why men might be a little bit more at risk. However, in more senior years, we understand that women then would catch up to this particular risk. And this is something that we really need to pay a lot more attention to. There's a lot of research has been done over many, many years with respect to trying to aid and prevent heart disease. So I'd like to focus on a couple of reasons why heart disease continues to be an ongoing problem. We have some fantastic medications and new developments that are occurring all the time. And these are primarily focused and targeted to lower blood lipid levels and to lower LDL cholesterol. But ultimately, there is no cure at the present time. Despite receiving some of these lipid-lowering medications, many people still remain at risk. And in the research field, we call this residual cardiovascular risk. So despite you taking medication, you still may be at risk of developing and progressing to having a heart attack. We also know that a large group of people that have a clinical event or a heart attack or a stroke can also have normal levels of LDL, which means there are other processes and other pathways, as you saw in the previous slides. This particular process can be quite complicated and doesn't rely just on one risk factor. This particular slide is just to help you understand that despite having either lower LDL concentrations or higher LDL concentrations, either with medication or without, there is still ongoing risk of having a heart attack or a clinical event from vascular disease. These lines here represent the time in years to a particular event. And so the lower the graph here, the faster someone will be at risk of having a heart attack. And despite having lower LDL or despite having medications to try and prevent heart disease risk, there is still that residual risk that remains. And this is where some of the interest in understanding why that might be the case. And I'd like to share a little bit more about that research with you. We know that poor metabolism of blood lipids can result in the accumulation of lipids into blood vessels. We know that more blood lipids that can circulate, they start to accumulate more rapidly. And interestingly, we know that there are more blood lipids during the non-fasting state or during the course of a day. We know that during the day, these non-fasting blood lipids can be easily measured. And I'm going to talk a little bit more about remnant cholesterol in the next few slides. During the morning in the fasting state, we know that parts of the body contribute to the availability of cholesterol and blood lipids. And you can see some of those examples here. We've mentioned LDL cholesterol, and we know that as clinically, we measure LDL cholesterol routinely and has been related and is related to increased cardiovascular risk. High blood cholesterol concentrations of LDL cholesterol indicates a higher cardiovascular risk. And this is something that we have traditionally been able to treat. However, what's less known is the contribution of blood lipids during the non-fasting state. During the day and in the non-fasting state, there are other organs that can help contribute to increase blood lipids during the course of the day. And a good example of this is the dietary contributions of lipids, and the intestine helps to absorb those lipids and has to circulate those blood lipids during the course of the day. And that contributes to having increased amount of blood lipids throughout the course of the day. If the metabolism of these lipids is impaired or is not sufficiently fast, then blood lipids during the course of the day can contribute to cardiovascular disease. I'd like to just share with you an analogy here. I show you a cross-section through the bloodstream where a lot of these cholesterol particles are circulating, and we know that these particles in higher concentrations can get into the blood vessel where they can accumulate. When we measure blood lipids in the fasted state, we see and identify certain amounts of blood lipid cholesterol, and we understand how much is available to the vessel wall in the fasted state. However, in the non-fasted state during the course of the day, we know that there are higher blood lipids. You can see here just a representation of an increased number of blood lipids circulating in the bloodstream would then equate to the probability and possibility of having more cholesterol accumulation during the course of the day. And this is something that we think is very important to understand, but also very important to measure. So we think that measuring blood lipids in the non-fasting state during the course of the day might actually be more relevant for all pathways of CVD and heart disease risk. We are able to measure non-fasting remnant cholesterol during the course of the day relatively easily. If we measure total cholesterol in the non-fasting state during the day, and we measure LDL and another form of good cholesterol, HDL, if we measure these during the course of the day, we are able to calculate the contribution of remnant cholesterol that occurs during the day. So it's relatively easy to calculate by taking a blood sample during the course of the day. And in Europe, there have been many studies that have included hundreds of thousands of people to date that have been very interested in this non-fasting remnant cholesterol and the relationship to different forms of heart disease and cardiovascular disease risk. I'm showing you just one graph which shows increasing remnant cholesterol concentrations cause an increased risk factor of up to 2, depending on how much remnant cholesterol you have. So this has demonstrated that with increasing amounts of this non-fasting remnant cholesterol, the relationship is that there is increased cardiovascular risk in those individuals. We also know that compared to LDL cholesterol, remnant cholesterol also has higher cardiovascular risk probability in many different forms, either ischemic heart disease or even myocardial infarction. The relationship between non-fasting remnant cholesterol and increased risk, as you see in these red lines, are higher than what has been measured for LDL cholesterol. We also know that when individuals are already on medication to lower LDL, for example, taking a statin to control and lower LDL cholesterol, that the relationship of increased remnant cholesterol and cardiovascular disease still remains very positive. So measuring remnant cholesterol in these situations is still very, very important. Here in Edmonton at the University of Alberta, we've been working with remnant cholesterol for quite some time. And more recently, we've been trying to advocate and create awareness around why it might be useful and more informative to measure remnant cholesterol through measuring blood lipids throughout the course of the day. And this is just one of the screenshots from the website if you'd like to learn more about that particular campaign that we have at the University of Alberta. What I would like to share with you is a short animation video of about 1.5 minutes, so not too long, but it tries to summarize some of the concepts that I've just explained and might be a good summary for a couple of slides that I'd like to share next, which would be some of the data that we've been measuring remnant cholesterol here in Alberta. So I'm just going to see if I can play this particular video for you, and hopefully you'll be able to see and hear.
Each year, heart disease causes 17 million deaths, making it one of the leading causes of mortality worldwide. To prevent this disease, doctors have been focusing their attention on LDL cholesterol, the so-called bad cholesterol. Unfortunately, half of those who have a heart attack have normal levels of LDL cholesterol. Contrary to conventional wisdom, LDL cholesterol is not always the best predictor of heart problems. To address this issue, scientists at the University of Alberta have been studying a new measurement of cholesterol called remnant cholesterol that is potentially more sensitive than LDL and may catch heart disease much earlier. Heart disease occurs when the flow of blood is blocked due to the buildup of excess cholesterol in arteries. In the past, scientists have measured LDL cholesterol to make sure it doesn't get too high. However, historically, this is always done in the morning, in the fasted state. As we eat during the day, our bodies produce remnant cholesterol, which scientists at the University of Alberta have discovered can also contribute significantly to heart disease. Measuring cholesterol in the non-fasting state may be more sensitive at determining the risk of a heart attack, and many countries have already moved to measuring non-fasting cholesterol, which is helping to save lives. New findings show that people here in Canada who have higher levels of non-fasting cholesterol have an increased risk of a heart attack. Canadian lipid guidelines are now encouraging physicians to measure lipid profile in the non-fasting state. By measuring cholesterol during the day in a non-fasting state, we can better predict the risk of a heart attack and potentially save lives. For more information about our work, to support us or participate, please contact us online.
So I'd just like to finish with sharing with you some very new data in collaboration with some of my colleagues at the School of Public Health at the University of Alberta, in which we had access to a cohort or a database called the Alberta Tomorrow Project. And I want to start by just sharing a little bit more about what the Alberta Tomorrow Project is. And then I can just explain to you how we collected some of that data and share with you some of the results that pertain specifically to women in this particular cohort. It's very interesting and quite exciting. This is an ongoing prospective cohort of people, a database that's the largest of its kind in Canada. And one of the reasons why it's so unique is because the blood samples that were taken from some of the individuals during the enrollment period did take blood samples in the non-fasted state. And so I hope you can recognize that having blood samples taken during the day allow us to have an accurate calculation now of remnant cholesterol that I've introduced to you. So during quite a number of years, the ATP project team enrolled about 50,000 participants, one of the largest Canadian cohorts of its kind. And from 2008 to 2015, it also combined with the Canadian Partnership Tomorrow Project. So it includes not only Albertans, but individuals from across Canada. Initially, it included detailed questionnaires on lifestyle and dietary intake and medical history. However, a portion of these volunteers also had a non-fasting sample taken, which allowed us and is still allowing us to do lots of different measurements, biomedical measurements. And one of the first measurements to be done was actually to measure the blood lipid panel. And so some of that data I'll be able to share with you. At the same time, participants in the ATP were also provided consent to access their more recent medical data linkage. And so what that means is we can combine these two databases, which allows us to access whether someone may have developed cardiovascular disease and what type of cardiovascular disease they may have developed. And we'll be able to track and assign and analyze the relationship between fasting remnant cholesterol and some of their history or medical developments. And so one of the questions that we asked with this particular data set was to determine the relationship between non-fasting remnant cholesterol and compare that to LDL cholesterol, how much of an incident cardiovascular disease was in this particular population, and specifically in females. So the way the analysis works is you begin with the complete pool of volunteers, approximately 52,000. And depending on the data sets that are available and depending on the interest of the question, in our case, women, we were able to assess approximately just over 10,000 data points of full lipid panels, calculating remnant cholesterol, and using relationships to incident cardiovascular disease and different forms of heart disease. This is what the baseline characteristics of that particular data and cohort look like. Some things that may be of interest. On average, the females tended to be about 60 years of age, plus or minus about 10 years of age. About 675 events were recorded. So about 7% of those females had cardiovascular disease or had some form of a cardiovascular event. About 15% of those people were already on lipid-lowering medications like statins. And you can see here some average lipid panel results from the cohort. LDL cholesterol sort of borderline, depending on the absolute situation of the individual, but upwards of 3 millimoles per liter would be considered borderline to high. And we were able to calculate and measure remnant cholesterol. And you can see here the values assigned on average to this particular cohort. What I'd like to introduce to you now is the results that explain the relationship between the non-fasting remnant cholesterol value, and you can see here quartiles of increasing amounts of remnant cholesterol, so higher blood lipids of remnant cholesterol, increasing as you go from left to right. And you can see here, the first relationship is that as remnant cholesterol blood concentration goes up, there are higher number of incident CVD cases in these women. And there is a linear relationship between the highest concentration and the highest number of cases. We were also able to correlate that with statin use within the cohort. And that's plotted here in these red circles on top of the bars. And what's interesting is that despite the highest number of statin users, in the highest proportion of those who had heart disease, we still had very high amounts of remnant cholesterol. In comparison, we did not see the same relationship for LDL cholesterol that was measured in the same women. We see some relationship in quartile 2, 3, and 4 with increasing amounts of cholesterol and increased incident CVD cases. However, what's very interesting is that the highest number of cases of women had a relatively quite low LDL cholesterol value. And interestingly, this group also had the highest proportion of those already taking lipid-lowering therapy. So what this tells us is that groups of individuals who are already on medication, who might have a somewhat healthy or normal LDL cholesterol level, may well still be at risk of having a heart attack or a cardiovascular event. And some of this explanation may well be because they might have high concentrations of non-fasting or remnant cholesterol levels. One of the other things we were able to ask is in women with or without cardiovascular disease, shown in red and gray, what is the concentration of non-fasting remnant cholesterol? And you can see quite clearly there's a small, slight increase in the concentration of cholesterol in those women that already have cardiovascular disease. And this is highly significant when we apply statistical analyses. However, this was not the case for LDL cholesterol. And in fact, while there's even just a slight reduction of LDL cholesterol in those women in this particular cohort that have cardiovascular disease, which indicates to us that measuring LDL cholesterol may not necessarily be telling the whole story. And I think this is one of the main take-home messages that we'd like people to understand. And finally, one of the analyses that we're able to perform is what's called an odds ratio, where we ask the question that increasing remnant cholesterol of 1 millimole per litre increase, what is the additional risk to those women for having an incident cardiovascular event? And in this case, the value for remnant cholesterol was about 1.7. So above 1 means an increased probability of having cardiovascular disease, whereas that relationship was not true for LDL cholesterol in these women. So just to wrap up, I'd like to leave you with a couple of not only research take-home messages, but also some other thoughts about some of the ongoing things that we might be doing in our laboratory with respect to heart disease health. So from what I've shared with you today, we know that heart disease is different in women compared to men. We know that women are at greater risk of cardiovascular disease and heart disease later in life. We know that identifying heart disease risk early in life still remains complicated and it's not simple, and there is not yet any cure for heart disease per se. We know that blood measurements are recommended in the non-fasting state at any time during the day. And studies in Europe and now in Canada are suggesting that these non-fasting blood lipids may actually be more useful to identify CVD risk. And I've shown you some of that data, specifically studies in women. I'd like to finish by just sharing with you some of the ongoing and future questions that we're asking from a research point of view. You saw some of the interest in having campaigns to raise awareness of non-fasting blood lipid measurements. And we're very interested in targeting not only women, but also youth that might be susceptible or at risk. We have some other new data that suggests that overweight youth also have risk of lipid intolerance and high levels of remnant cholesterol, and therefore they may be at early risk of having development of cardiovascular disease. And finally, we're doing something slightly different, and we're leading with collaborators, an international consortium to develop a new antibody against the development of vascular disease, which is quite a different approach compared to just targeting lowering blood lipids. So I just, again, my last comment here is how can I advise or help or advocate for my own heart health? And I think just to reinforce some of the things that you may already know, raising questions or concerns with your family doctor or physician, and make sure that you can establish those relationships and establish new relationships if you don't have a regular doctor is also recommended. I think many of you would appreciate that as we age, we need to be aware of increased risk of heart attack and a cardiovascular disease. And we need to appreciate that we must have an active lifestyle and good dietary habits. And recommendations are readily available from Alberta Health Services and other resources in the province and also in Canada. And of course, for those with families or younger family members, remembering that cardiovascular disease progression does begin early in life, and it's never too early to learn more about heart health. So I'd like to thank many of the collaborators. Some that I've highlighted here have contributed specifically to some of the experiments that I've shared with you today. But of course, I'd like again to thank the Alberta Women's Health Foundation and the team for giving me the opportunity to speak and to share some of this information with you. Thank you very much.
Thank you so much for that informative presentation, Dr. Proctor. I know I learned some new things, and I actually have a question. So I'm going to be facilitating the question and answer portion of this evening, and we have received some great questions. So I'm going to go through those. And if you do have any further questions, folks that are on the call that you haven't posted in that chat yet, then please go ahead and do that. And I think the question that makes the most sense to start with is one was asking, how do we define a cardiovascular incident? So what types of incidents and how do we define that as an incident?
So of course, there are many different forms of an incident, and so it would depend where in the body or what type of blood vessel that the disease would progress into. And sometimes I mentioned earlier on about plaque rupture. When there is plaque rupture, some of that material can relocate into smaller vessels. And this is what we call that dangerous third phase, when it can happen spontaneously at any time. But the different forms of cardiovascular events will depend on which blood vessel is blocked, and therefore what part of the organ, whether it's the heart or the brain or other areas of blood vessels, which one is getting blocked and what areas are not getting oxygen. So I'm hoping that's close to answering part of that question.
Yeah, I think essentially the type of blood vessel that's involved determines the type of cardiovascular incident. Yes. Or cerebrovascular, if we're talking about the brain. And when we're looking, I think potentially the question is also with respect to the research. When we're looking at some of your research and some of the definitions were sort of like the levels of LDL versus remnant cholesterol didn't necessarily predict a cardiovascular event. Was that specific to like a heart attack, or was it just like you said, like this variety of events that could occur?
Yes. So some of the details when we start to analyze this information, of course, the registry does input a certain code for a particular event. So when someone is on the ward and is being treated for that particular event, the physicians will have to enter in the rationale or why they're on the ward, and there'll be many number of codes or numbers that refer to this specific cardiovascular event. And so that information is captured, and we can take as many different codes, and we can use that information to make sure that we're capturing all different forms of cardiovascular disease.
Fantastic. And I think the next theme with our question has to do with remnant cholesterol and the actual measurement itself. And so a few different folks have asked, how do we need to ask our physicians to order a remnant lipid level? And I think my understanding is that it's a calculation based on a non-fasting lipid panel, but maybe you can help us. How would one instigate that conversation with their family doctor?
Absolutely, it's a very important question, and I did show a slide earlier that shows, as you state quite correctly, it is a simple calculation and can be done using the existing measurements. And so I think for a conversation with a family doctor or physician would be to say, can you explain the differences between a fasting blood measurement in the morning in the fasted state, or the difference being, can I get that blood sample taken during the day? And the current lipid guidelines are actually advocating that physicians do ask patients to go during the day in the non-fasting state, and that allows them to calculate then remnant cholesterol from the traditional lipid measures that you might normally see either in a hospital in the labs, or from particular other labs that can do those measurements. So it's a simple calculation from existing lipid levels. The trick is just to do that during the day in the non-fasting state.
That's fantastic, because we're already running lipid panels. It's just to make sure that we run the panel at the correct time of day, and then finding that calculation. And then is there a reference range for that calculation that has been established that folks can access, or is that something they should just identify on an individual basis with their GP?
So that's another excellent question. There have been reference ranges developed in Europe, and so there are international guidelines that can help physicians who are interested in understanding the level of remnant cholesterol and how it's associated with risk. In Canada, we haven't been able to develop those reference ranges yet, and so that would be a limitation for the physician right now. But as you can see, we're trying to do the research in order to gather the data points in order to start to develop reference ranges for sure.
And along those same lines, there's a question here asking, does increasing your good cholesterol or the HDL help to reduce the remnant cholesterol?
Yeah, so I didn't get an opportunity to talk much about the good cholesterol, so that's another excellent question. So many of the calculations of risk, and actually including the remnant cholesterol calculation, usually we offset good cholesterol with the bad cholesterol, and we try and take one away from the other in order to make sure that we're balancing the overall risk. Good cholesterol is thought to be able to remove cholesterol from blood vessels. And so you could envision, and maybe you could visualize, higher good cholesterol might mean lower bad cholesterol in blood vessels. And so exactly right. We have to take into account high good cholesterol, HDL measures. And if you remember the calculation for remnant cholesterol, it was actually LDL cholesterol minus HDL cholesterol. So certainly someone with high good cholesterol, that's a positive thing with respect to understanding their level of cardiovascular risk.
Fantastic. So that we still like HDL.
Yes, we do.
Okay. And another few questions came in about statin medications, and I'm going to try to lump them together a little bit. So the first question would be, do statins also help to lower remnant cholesterol? If not, what does? And I think we answered that a little bit already with respect to the HDL, and we know that things like nutrition and exercise, I think, can impact HDL. And then there's also the part of, is there, and this is a very specific question that I think is really interesting, is has any of your research, are you familiar with any research that has identified a particular time of day that may be better to take a statin medication?
Okay, maybe last question first. Time of day for statin medication. No, I don't think so. I think statin medication, depending on whether you're taking one or multiple tablets a day, I think often it's just one tablet a day. It would be probably first thing in the morning or as recommended by the physician. Sometimes, depending on the statin formula, sometimes they ask you to take it with a meal. So that might be one of the recommendations. But as far as time of day, and maybe the question is alluding to your first question was, do statins actually help remnant cholesterol? And so maybe those two questions are a little bit related. And the answer is sort of. Unfortunately, it's a little bit complex and not so straightforward. What we do know is that the metabolism of lipids during the course of a day use very different pathways as compared to LDL. And so you're dealing with different metabolic pathways to help control and regulate blood concentrations when we talk about LDL versus remnant cholesterol. And so they're very different metabolic pathways, and statins have been developed solely to try and lower LDL cholesterol.
Right.
Having said that, there is some overlap, and we have seen that quite strong statin medications can impact remnant cholesterol and blood lipids during the day, but they're not as effective. And so the data that I did show with one graph showing increased statin usage, those individuals still had high remnant cholesterol concentrations. So I think the simple answer would be statins are not strong and effective enough to overcome some of those lipid pathways that we're using during the course of the day.
Okay. Thank you. I am not even going to attempt to summarize your answer because I feel it was so complete. And I think it's really interesting, leaves us with, more questions and research to continue to, confirm what good next steps are overall for folks. Now, along those, staying sort of on the medication line, someone has asked, do cholesterol meds that prevent fat absorption in the colon mitigate the risk of cardiovascular disease?
Yes, so these particular compounds have been shown historically to be quite effective. One of the concerns is the side effects of a number of those compounds. They can be quite strong, and some of the side effects are felt by many people who are taking those medications. So again, it's a balance of understanding what the benefits might be from some of the medications versus now what the detrimental effects are on being able to tolerate some of those medications. And maybe just to expand a little bit, this idea of combining medications is also very interesting and can also be very useful. As I mentioned, there are different pathways of fat absorption and fat metabolism. And so if you're trying to, or your physician is trying to combine different compounds, sometimes there can be more efficacious results in controlling blood lipids. And you're able to control some of those side effects by reducing the overall amount of a particular medication so it becomes more tolerable to the individual. But some of those individual responses and side effects are quite personalized, and it does depend on the individual and some of the the medication.
Right. So the side effects may not always be tolerated. And so we're always choosing medication from like a benefit versus a potential risk scenario. And sometimes we will stack medications in different ways in order to mitigate side effects that one might cause, or to be able to use a lower dose to get a same response in a sense.
Exactly. So this is where the expertise of the physician and the specialist now is very important to be able to manage, the dose and the side effect and the individual.
There's a question here about just on the topic of physicians. Some physicians might look at the overall cholesterol level versus looking at individual values. For example, individual interpretation of values could influence the physician's cholesterol health determination. So I think the question is sort of about like, how does interpretation impact patient care, and do we, because when you talked about education campaigns directed at women and youth, how are we also targeting, this is kind of two questions in one, physicians, right?
Yes, I mean, maybe you're asking how do we help educate the health professionals and get them to understand some of these new emerging research parameters that might be helpful. I agree. Not only does do we need to be well informed, and we need to learn and help advocate for ourselves, but we also need to make sure that some of this information and the continuing education in the medical program is also up to date. And so, yes, you can certainly see that the campaign and education needs to be had on both sides, for sure. Back to the understanding of how does a physician interpret a lot of this information for a particular individual. And this is why the management of this particular disease can be so individual and so personalized. I do have one slide, which maybe I might try to quickly go to if I have time. It really highlights the fact that the interpretation is really quite important. If I just share my screen again. So this is from the most recent lipid guidelines from Canada. And you can see that these flowcharts are designed to help physicians interpret situations with different individuals in different circumstances. So it's not just relying on one particular value. It actually combines and allows the physician to measure other values and incorporate that into their interpretation. And we could debate the importance of remnant cholesterol or ApoB or LDL, and many physicians and specialists do debate this, a lot more than I do. But this is really just to give you a very good idea that it's not straightforward. And there are a number of parameters that they have available to measure, including inflammation as well. And these biomarkers are sometimes pulled together with health behavior modifications, and whether lifestyle modifications are possible, whether change in dietary pattern is possible, whether exercise is possible. All these things will help convey a particular interpretation for the physician to try and maximize the lowering of potential risk. So if the risk is low, then sometimes medication intervention is not required. But if the risk is high, then you might consider not only lifestyle changes, but also initiate statin treatment, as soon as possible. So just to give you an idea, it's not one size fits all. And a lot of information goes into providing advice and guidance about how specialists will actually come to their own interpretation for a particular individual.
And I saw on that slide the FRS scores, which are the Framingham risk stratification
Yes, scores.
scores.
Yes.
Scores. That was actually one of my questions, was how does the Framingham risk score play into using remnant cholesterol as a gauge of risk? But I think that slide and that paper probably does a good job describing that. But do you have any additional thoughts on that?
No, so the Framingham risk score is something that North America uses quite heavily, and that's because it has been developed historically and has provided some of the most important data sets and includes the most information that we know in North America about our population in order to calculate what we call lifelong risk. And so it's not just about one number at one particular point in time. It's about a particular number over the span of life years. And you can see from those early slides that it's not just one point in time. It's actually what happens over the lifespan that might increase or decrease your risk. And so the Framingham risk score has been developed over many, many years with lots and lots of data points in order to try and help physicians come up with an overall lifetime risk score. And that's something that is used in North America primarily.
Okay. And it's fascinating to know that it's a North American standard, because I think we've all seen it on our lipid reports.
Right.
There's a collab comment usually that'll tell us, tell the individuals as well as physicians, what the Framingham risk score is and how to establish that and calculate it. So interesting to know that, the European guidelines, I know you said it do integrate reference ranges for remnant cholesterol. And so again, digging back into that a little bit, some folks have been asking if there are other ways to reduce remnant cholesterol other than raising HDL, and is diet or exercise the only way to raise HDL, or are there other things that you're aware of that might help folks understand how to manage remnant cholesterol in other ways?
Yeah, so it's the obvious natural next step. So what can we do to advocate for ourselves and our own health, and how can we help ourselves, so to speak, without medications? I think following Canadian nutritional guidelines for healthy eating and making sure that diet is being followed. If you think that's something that can be changed, you can certainly reach out to a registered dietitian in order to get an evaluation of your particular dietary habits and how you might learn to change that if you need to change that. There are some specific, nutritional highlights that we would probably, say that making sure you've got fish intake incorporated into your dietary intake. And maybe even certainly considering fish oil supplements could be something that has been shown to be very good with managing blood lipids. If that's something, high triglycerides, for example, the omega-3 supplements have been shown quite effectively in some studies for high blood triglycerides. And certainly, if exercise is not already incorporated into the daily routine, that's always one that's quite difficult to have on a continuous basis. But it is something that has been shown to help a number of different metabolic pathways. And so, if those avenues are not being considered, they're some of the first things and to consider. And sometimes those big lifestyle changes can make a big difference to things like good HDL, lowering LDL cholesterol, and your overall blood lipid health. It's when there's a little bit more of the genetic incorporation, which is difficult to understand without those specialist tests. Without the help of the physician, it's difficult to understand whether you've got some of those hereditary risk factors that are contributing to your risk. So certainly lifestyle is a big part. Dietary habits are a big part, and learning more about those from recommended sources would be the first place I would go to.
Fantastic. So yes, it is something that we can impact with means other than medication, but medications are sometimes and often necessary to manage risk. So
Correct.
Questions. So because you mentioned triglycerides, and this was the question, one of the questions that came to my mind was, and you even kind of alluded to the genetic situation. What about that concept of familial hypertriglyceridemia, or like just genetically high triglycerides? And then someone else had a question, they're kind of different, but they're related. Someone else had a question about what happens if we have a very high fat meal in the 24 hours or in the hours even preceding that non-fasting lipid panel. That's usually going to cause our triglycerides to be a little bit high when we get those test results back, because triglycerides are, my understanding is that they're the fats that are dissolved in our blood.
Yes, excellent question. And again, I might fall back on a slide just to give a visual, but certainly you might see some slight increases in blood triglycerides if you've had a meal that's high in triglyceride. You're absorbing that, and the body has to digest and then has to metabolize. So yes, you might expect that the triglycerides might increase during the course of a day following a fatty meal. But the levels of remnant cholesterol have been shown on average not to significantly change depending on the type of meal. So if I give you a fatty meal today and I give you another fatty meal, in 3 days' time, the values of those particular levels won't necessarily change too much. And so for the individual, the triglyceride results and the cholesterol results are still valid for that particular individual. And some might say measuring high triglycerides during the course of the day, if the physician sees that information, that's actually more important to the physician, because the physician now knows that following a meal, the person is having trouble metabolizing those fats.
Right.
Whereas if you're only taking blood samples during the morning in the fasted state, the physician's not going to know whether you have high triglycerides or not. And so a number of recommendations in the lipid guidelines are that they're actually recommending measuring these blood lipids during the course of a day. And if there are high triglycerides, then you might want to go back to some fasting blood lipid workup and investigate further, because high blood triglycerides can mean, as you mentioned, some genetic underlying, which might need further follow-up. But certainly high triglycerides might also mean that you've got a lot of these remnant cholesterol particles or high LDL particles with lots of triglyceride. And so knowing your triglyceride values and whether they're going up and down during the day is also very useful from the interpretation point of view.
Fantastic. So that also helps understand the difference between fasted measurements and the measurements as we go throughout the day. And that does still give us some information about how we're tolerating or metabolizing those dietary fats that we're taking in.
Correct.
And so to bring it back for a moment to the context of women's health overall, a few questions came in. How are you doing, by the way? We're asking you a lot of rapid fire questions.
I'm good. I have my water. I have my water here, so I'm good.
Thanks.
Yes, thanks.
Fantastic. So with respect to hormone therapy, and so either estrogen therapy or are there considerations with remnant cholesterol and the initiation or continuing estrogen therapy post-menopause or perimenopause, for example?
Yeah, so this is not my area of expertise, so I'm going to keep fairly high level, but certainly for those more senior women that are post-menopause, I think I tried to explain, why there might be some loss of that particular protection, and the mechanisms within the blood vessel wall of how that changes the accumulation of lipids in the blood vessel wall, and how that might lead to increased heart disease risk. So, of course, as I mentioned, the way in which women lose estrogen and the rate at which they lose estrogen is going to be very individual and quite personalized. And that's why, quite a lot of workup during that particular period will be needed with your physician to understand how quickly or how slowly you might be losing estrogen. And this is where the interest lies with trying to mitigate the rate at which you lose some of these hormones. And so if you then ask about hormone replacement therapy, whether it's testosterone for men or even estrogen for women, there is a lot of evidence that says you can delay that increased risk of cardiovascular disease. But again, on the flip side, there is also a number of side effects that come along with that particular therapy and management. And so just like lipid-lowering medication, there is always this balance between the benefits over the side effects. For example, if a particular woman is not displaying, high risk of cardiovascular disease, maybe there isn't really the need for hormone replacement therapy if that's causing a number of other additional complications. And so, yes, you can delay that onset of increased risk during that time by considering these things. But I think I would like to say just raising that with your physician, who would be able to better explain what the benefits and the disadvantages of some of that medication might be, would be the best place to start.
Right. So always reviewing those pros and cons, risks and benefits. Is estrogen therapy something that might help reduce my risk of cardiovascular disease, or am I choosing this for other reasons? And what are the risks associated with it overall?
Yeah, and maybe I could add, I focused today quite a lot on just the blood lipid panel and what we can do with estimating and predicting with blood lipids and understanding values. What I haven't spoken about is that there is a whole other side of evaluation which involves imaging, which can provide us with much more power of understanding an individual's level of risk. So, so someone, for example, who might be genetically susceptible, they might require some of these more advanced and sophisticated follow-up and analyses which are available, and they can give you a better understanding of your maturity of vascular disease, whether you have vascular disease in certain blood vessels, whether there's a calcium score associated with that. So it can be followed up in a lot more detail for certain individuals. And that then becomes far more powerful to say someone has vascular disease, we now need to take a little bit more steps, and vice versa. The vascular disease is not very is non-apparent in certain vessels in an older woman, and so the level of risk might be a little bit lower. So there are a lot more opportunities and tools available to the specialists that can certainly contribute to that particular conversation.
And that's fantastic that you mentioned imaging, because some folks were asking about, is there a way to know if my arteries are all plugged up? I think was almost the exact question in the chat. And so do you want to tackle that a little bit?
Yeah, again, this is not my area of expertise, but we do collaborate with many people who are excellent at what they do. Many of them are at the Mazakowski and at the University of Alberta. So there are a number of different, modes of technology that allow people to have access in the clinic. So they would be things like handheld ultrasounds. You can use handheld ultrasound to measure, certain blood vessels. One very common one is the carotid artery, which leads from the heart to the brain. This is one that can give you a very good indicator of how much vascular disease you might have developed over your lifespan. And so there are lots of algorithms and calculations that they use with ultrasound. There are other more sophisticated levels of ultrasound that are not portable. They're a little bit more static, which you might go to see a particular specialist, that give you far better resolution. And when you do that, you have a much better indicator of, let's say, plaque volume, and you can measure how much area or plaque volume exists in a particular vessel wall. And that gives you far more detailed information about the potential risk. And then, of course, things like MRI can be adapted to specific blood vessels. Of course, those machines are not only expensive, but they are very heavy, so they're not portable. So there are a number of different levels of imaging that are available. And again, just to reach out to you at the beginning, to your family physician, but certainly your specialist would certainly know how to get access to some of that technology if you think that's warranted.
Fantastic. So I think you covered all the different types of imaging that somebody could possibly access or need, and it would be up to the physician and the specialist to determine what the best thing was for that patient. So yes, there are ways to determine what's going on with our blood vessels and our cardiac system overall, but we're using these surrogate markers, the blood work, as a risk assessment. Do we need to go further? Do we need to look more?
Correct. So again, one last point to add. There've been lots of thoughtful questions around the different avenues and opportunities of understanding our heart health, and I've tried to give a little bit of insight into how some of these lipid measures might be used to first identify those people who might be at risk. Of course, we don't want to have to give an MRI to everybody, because that takes time, it takes money, and we're not always able to choose the right time, especially when someone's not at risk. But the blood lipid panels are sufficiently cost effective that allow us to screen large numbers of people, including children and including adults of all ages, to hopefully identify whether someone might need additional follow-up. And this is one of the goals of our ongoing research program is, if LDL is not a great marker when someone is young, are there other lipid markers that we could use to screen those that might be at risk so they don't get missed? Because what we're trying to avoid is the overweight youth goes to an overweight adult, and it's not until they have a heart attack when they're 40 or 50 does anybody pay any attention. And I think this is one of the things we're trying to learn about. We really need some early, cost-effective ways of identifying those people at risk a lot earlier on than what we're doing right now.
And I think that's really exciting, because it's that we have this opportunity to impact future generations and improve their quality of life and their health if we're able to figure out how to screen early and deal with the prevention before it becomes full-blown disease or an incident, like you mentioned. We're really close to our time, but Rhiannon, who is our other facilitator, asked me a really good question. Do you know if there's ways that we can participate in these kinds of research studies?
Yes, absolutely. There's always interest and need. I will say, post-COVID, it was a challenging time for everybody, not only personally, but also from a research point of view. And there's always ongoing clinical trials, and they require volunteers and patients in certain situations, depending on the trial. And you can certainly contact Faculty of Medicine and Dentistry or a number of the clinical associations at the University of Alberta. Some of these centres are collaborating sometimes all over the world, but certainly all over Canada in order to develop sometimes different medications. Or there might be smaller scale clinical trials like we do in our own laboratory, where we're trying to compare certain people with certain disease parameters. And we certainly have the ability to do lipid testing in our laboratory, and we're always looking for partners and volunteers. So there are lots of opportunities to be involved, and lots of opportunities to learn more about heart health for sure.
And we're so lucky to have access to such local resources and data generation, and to be part of that. So thank you for your work, and thank you so much for this discussion tonight. I'm just going to share my screen real quick here, and hopefully that'll okay, perfect. And yeah, thank you so much. And thank you for dealing with all of these questions. This is, I think, the most discussion I've ever facilitated. So it's a lot of fun for me. I do enjoy learning about all of this. So thank you so much for presenting and for all this actionable information that we can continue to learn more about and advocate for our own health, and ultimately better care, better screening, and better results for not only ourselves but future generations, like we said. So thank you so much to everybody for attending. If anybody would like to continue to support the Lois Hole Hospital Women's Society, we'd love for you to consider becoming an active monthly donor. And you can scan this QR code that's on the screen, and that'll take you right to our website where you can sign up to learn more about our Lois Hole Hospital Women's Society mission and our accomplishments so far. Thank you to those of you who already donated during your registration, and to all the individuals and businesses that do support us monthly and continue to join us at these fantastic discussions. So thank you so much to all of our supporters, and thank you so much to Alberta Blue Cross for sponsoring our What the Health Talks. You will get a feedback survey, all of you, sent to you shortly, and if you can fill that in, you'll be entered to win and draw the $25 gift card courtesy of Alberta Blue Cross. So you'll be contacted by a Blue Cross representative when you do win the gift card, and it is real. So it's not one of these scams. You will actually be potentially a winner. So do fill out our feedback survey. Our next talk will be held in March. And the topic, I believe, is birth trauma. Thank you, Dr. Proctor. Thank you so much for being part of this with us. I know I learned a lot, and I'm excited to share that with friends and family, and I'm sure everybody here also learned a lot. So thank you so much for joining us, and thanks to everybody else. I hope everyone has a wonderful evening, and thank you for your continued support.
Thank you, everybody. It was great opportunity. Thank you for your questions and for your interest, and it was a real delight. Thank you.
Fantastic.